Stan Saban, and I'll introduce Dr. Jacques, Gary Jacques, we just met. But Dr. Jacques, an internist, board certified, with many years of experience in global health, including 8 years working in Cambodia, leading the development of an NGO-based healthcare system that has a profound effect on the nation's healthcare sector. He was a small coalition, part of a small coalition of public and private partners that helped Cambodia pilot and then scale up a comprehensive HIV/AIDS response for which the country was awarded the MDG Prize for Excellence in 2010. What is MDG?
Millennium Development Goals.
What?
Millennium Development
Goals. Okay, excellent.
They're replaced now by the Sustainable Development Goals, whatever.
Okay. In this award, the UN recognized Cambodia for its efforts on HIV that have contributed to a decline in HIV prevalence from an estimated 2% in 1998 to 0.8% in 2008. The countries also achieved the universal access target for antiretroviral treatment, with over 90% of adults and children in need receiving treatment.
Okay, thank you. Great. It's a pleasure to be here. Thank you for the opportunity, for all those that have given that opportunity. And just to start out with, I wanted to see how many are medical physicians or in a medical field, how many are in public health? Medical, public health. Okay, so I'm an MD, so I'm outnumbered, and that's great. And like I said, you can have fun with this presentation because this kind of, in some ways, is a story of medical doctors trying to learn public health. By way of personal introduction, before we jump in, I actually grew up along the Front Range here in Colorado, so up in Boulder County near Niwot. I went to California for college and med school, Vanderbilt for my internal medicine training and some time on the faculty, and then as we've heard, 8 years of living in Cambodia. I've been with this organization doing this work for 15. Let's start out with just a story. One of the heartwarming stories that I heard 15 years ago was of a young girl. It's not this particular girl. This is a representative young girl. And she was a teenager that lived out in a very rural aspect of Cambodia. And she was run over essentially by an ox cart. She ran into one of these, a water buffalo bearing cart, and it broke both of her femurs. And health access to care was not existent for her back in the day. A village traditional healer came in and prescribed a poultice of some herbs. And long story short, she had a non-union. The bone fracture never did heal, so she was paralyzed from that point on. She did get married, and she had children. She just had to scoot herself around kind of on her hands on the wooden floor of her hut. And one of the memorable bits of this story to me was she would use rags and tie them to herself and then off to her toddlers to keep them near her and to keep them safe. So whereas a mom could go after them if they were veering off somewhere, she just had to do that tether method. And one day she was discovered probably 5 or 10 years after her accident by the Cambodian Red Cross village health worker. Was coming through her village and found her and said basically, how can I help you? What can I do for you? And she said, she thought, and she said, I think I'd like a wheelchair. Now, the Red Cross lady said, I think I could do better than that. And she arranged for the long, probably back in the day, it might have been a 2-day journey into Phnom Penh, the capital. She said, I want you to see the Sihanouk Hospital Center of Hope, which is one of the hospitals you'll learn about today, one of the hospitals that we run. She was seen there, and we had some orthopedic doctors on staff. They, addressed the problem properly. They went in with some surgery, created a proper grafts and fusion of those bones. Had to do a lot of work with adhesions and contractures, but the end of the story is quite amazing because this young mother of several children can now walk and run and jump just like you and I can. So what an amazing story there. And as I got to thinking about her request for a wheelchair, those of you that know Cambodia know, it's basically in a floodplain. And if the rice paddies all flood, the houses are often up on stilts. The roads are all dirt, which turn to mud in the rainy season. And I couldn't, for the life of me, imagine how a wheelchair would have been that helpful to this young lady. But I'm telling you this story because to me it's a metaphor in a way. It's a metaphor that tells me that sometimes the things I ask for, the things I can imagine are too little. And that actually greater things are possible. And I think it's a metaphor for the case study that I'm going to share with you today. Because in some ways this is a story of it's a case study of a project that perhaps should not have worked. Or to be more precise, perhaps it should not have worked in the scope and the scale to which it has succeeded. And I think you can just think of this girl asking for a wheelchair. I think we came in with a wheelchair mentality of what we were going to do. And in fact, something much larger unfolded for us. So that's the story you're going to hear today. Case studies are just that. They're not evidence-based, rigorous research, but they are something that we can use to draw lessons learned. They are a way to put ourselves in somebody else's shoes, if you're public health, to understand maybe what are these curative care hospital people all about? How does that fit in? How can I understand the world from their vantage point and vice versa? How can I help them to understand the world from my public health vantage point? So a lot of exciting things, I think, are embodied in this case study. A lot of academic things that I hope will be provocative to you and that you'll think about in your careers ahead. First thing is to mention Hope Worldwide briefly. Hope Worldwide is a faith-based relief and development organization founded in 1991, as you can see, dedicated to serving the poor. It's a global community. We're in 74 countries through member organizations. It's mostly volunteer-driven, and most of its work is not at the scope and scale that you'll hear about today. We serve all people in need, regardless of belief, religion, gender, sexual preference, race, ethnic background, or anything. So we're basically not biased in any way. We also don't have a evangelical mission, if you will. We don't. We're not there to try to impart our faith per se, as much as to live out our faith. So that's Hope Worldwide, that organization. Here's Cambodia, located, as you can see, in Southeast Asia, fairly small country. The little blow-up shows a bigger part of the map, and I've circled the two places where we have hospitals and clinics. So, as you can see, the capital, and then down there in the south. To set the context, I'm sure everybody knows that Cambodia is not your ordinary developing country, but it has suffered a terrible war back in the 70s, right after our American War, Vietnam War, as we call it. They had the Khmer Rouge come in and take power for about 4 years. And it was a devastating time for them. And there's a movie just came out, Angela Jolie. I haven't seen it yet. First They Killed My Father, something like that, after a best-selling book by that name. But when I went over there in 2002, I moved over with my family. Cambodia looked about like this. The city had mildew because it's a tropical environment. Buildings needed facelifts. The streets were dirt, even in the capital. And boy, has it changed now. There's some nice glass and steel skyscrapers. The streets are all paved. We lived on a dirt road. People would drive their seat-glows along. The ox carts would come along and sell pots. Somebody would come along yelling out "numpang," which is the word for bread. And, we had one of the few cars in the city, but the potholes were so fierce that you could go about 4 miles an hour. So that was Cambodia in 2002, all right, which is a long time after the Khmer Rouge were driven out by the Vietnamese and Cambodia started over. Part of the reason Cambodia is so that this was so devastating is every war is devastating and tragic beyond words. But and every genocide is unfathomable to me. But what made this one particularly fierce, I think, was that they singled out the educated class. So it was the doctors and the teachers and the nurses that were preferentially persecuted, that were considered a threat to the regime, and they all fled the nation or were killed. And at the time that the Khmer Rouge were driven out, all medical schools had stopped, all higher centers of higher education had stopped, and they estimated, I've heard, from 10 to 20, but in a ballpark, just a handful of doctors were left in the country. And so from that, they had to try to rebuild. There was still some civil war. There was guerrilla fighting out in the jungles. Even when we moved there, our Cambodian staff didn't want to go down to the beach 3 hours away because it was across some, guerrilla lines and that type of thing. So there was a lot of civil unrest until about 91. And in 91, the United Nations came in, brokered a transitional authority, and brokered some peace, put up a coalition government that didn't really last beyond a coup in 97, and they've been under the same government now from 97 on. That's the countryside. It's as much as the city has developed in the 20 years that we've been working there, paved roads, Lexus cars, the whole 9 yards, skyscrapers, evidence of wealth, evidence that some people certainly have wealth. The countryside remains fairly much the same, and it's still an agrarian economy. Probably out of 14 million, a couple million in the city, the rest are still in the countryside. And there still is a fair bit of poverty, even though Cambodia has made some nice strides and has just left the least developed nations into kind of the second tier of nations in terms of a development index. This is stats from 2011. So again, a good, what would that be? 17 years after we began working there, life expectancies had by then come up to 63. They're now higher than that. GDP per capita, 2,400, as you can see. Still, when I moved there in 2002, the doctors, any doctors in this group, they were paid about $40 a month. That was their salary. And $1 a day was decent living. So if you paid a housekeeper $1 a day, they were happy. You were not exploiting them, at least in their mind. We came in and offered our doctors $400 a month because you need a couple hundred to live. And what they were doing was they were working for their government, getting their $30, $40 stipend, but they'd just put in a few hours, make rounds, and then they'd go to their little home. They call them cabinet practices, where they would then practice medicine and glean $50 or $100 more dollars. And we wanted our people full time, so we said $400, that's a solid living wage. And we got some of the best and brightest, applying, because to them that was a pretty good deal. So if you're a physician in the United States and you're making $400 a month, I'm sorry, but that was a good deal for them. Here's our first hospital in the beginning. When I made this slide back in 2011, you can see it in the second over here. This is our staff had grown by then. We had gone from one unfurnished, unopened facility to 4 main building campus, some fee-for-service clinics, some mobile clinics, the largest HIV clinic in the nation, as you can see, a staff at the time of 460, about a $3.5 million annual budget. We had seen by then about 1.2 million patients, and we were recognized as a center of excellence in training. We have trained probably now, or contributed to the training of about 5,000 medical professionals. We trained in every area from laboratories, nursing, doctors, surgeons, radiology technicians, you name it. A little graph, I'll come back and we're going to drill down on all this, but what I'm doing, still in introduction mode here for you, is to go over kind of some of the growth curves that we experienced, because you don't have to, there's not even a scale on here, but whether it was patients served, whether it was professionals trained, whether it was the scope and scale of our HIV and TB work or whatever, we did experience in the 10 years or so that this slide was made, really pretty, I would say almost exponential growth. And that's an important part of the case study. Patient encounters, you can see that exponential looking curve, seeing around 50 when we opened our first year, 50,000, and back in 16 probably seeing over 200 and I think it was around 230,000 patients per year. So a nice exponential curve there. This is a picture of the first hospital 5 or 10 years ago, now with several buildings on it. There's our greatest asset, as I say, our wonderful staff. There's our second hospital. We opened this in 2002 down in Kampot, an amazing, I think about 26 building campus in a very rural and underserved part of Cambodia. There's a back-away view that shows you the Gulf of Thailand. There's a view of our staff forming the shape of a heart with the mountains, the Bokor Mountain in the background. And so you can see this nestled nicely between these wonderful mountains and the Gulf of Thailand. And if you would like to go and serve there, this is probably the best time for me to say, talk to me afterwards, because it's a gorgeous setting for sure. And there's the staff saying hello to you. And there's a slide with nothing on it. I don't know why. Last year we celebrated our 20th year anniversary, and this is the King of Cambodia and the Queen, the distinguished Queen Mother. That's actually his mother, with the distinguished lady in the gray hair there, at our hospital, giving gifts and helping us with our celebration. The hospital was named after Her Majesty's late husband, King Sihanouk. So that's why we're called the Sihanouk Hospital. We now have, as I said, 2 different hospitals, a set of medical centers, and a K-12 school that's quite distinguished. So in the 20 years, Hope has done some great things in this country. Probably, a $10 million budget and maybe close to 700 employees now across the scope of our work. So it has been a remarkable story, and what I wanted to do is share it with you and drill down a little bit. So in this section, I'm going to break it into 3 different phases. And in each phase, I said, let's share some challenges, some accomplishments, some surprises, and some lessons learned. And so here we go. The first phase, we'll call this a launch phase. When we first opened the hospital, we hired those wonderful doctors, paid them $400, as I said, got some of the best and the brightest that were to be found. And yet we immediately recognized, even with that they were sorely in need of training to bring them up to the kind of standards that we wanted, standards of care that we wanted to deliver. And so because of the language, because of different things, they all spoke English, but we did not speak Khmer. And they were our interface, and they were the ones that were going to be delivering the care. And medical knowledge was sorely remiss back in those days, that's for sure. So here's some of our challenges. We as an organization, we lacked organizational experience. We had not run a hospital before. So we got lucky. We got this opportunity to run one. And then it was, what do they say? Build the plane while you're flying it, or something like that. And we had people like myself. We had these wonderful doctors that were beneficiaries of wonderful Western education. So we certainly knew, and we had models in our head of what we wanted to accomplish. But in terms of actually doing that in a developing context, we didn't have that much experience. The workforce was unskilled, and so one of the biggest challenges was how do we build capacity in our own workforce. The need was huge. We developed a lottery, and we're often getting 600 people a day vying for spots to get in and to be seen. And we've stopped doing that now for different reasons, but there was just such a pent-up demand that if we were ever worried about will patients come to this hospital, by about day 5, we quit worrying about that. The business model was unsustainable. We were giving free care, and we still do to this very day. But what that requires is a huge fundraising effort year after year after year to try to raise $3 million roughly per year of philanthropic donations. Not really a sustainable business model. So, and another challenge was there wasn't really a national model. There wasn't really an example of a hospital that worked in Cambodia. There's 2 exceptions. There's one exception when we started. The Kanta Boba hospitals were a pediatric hospital. That was an NGO-run hospital. A little bit of a closed shop, and so it wasn't completely clear how they ran things, but they appeared to have, a pretty good hospital system going there. And then the Angkor Children's Hospital started about a year after we did, another pediatric NGO hospital. And so those were the exceptions. But the doctors and the nurses in our hospitals essentially did not have what you and I take for granted in America, which is a hospital that works. And by that I mean you see a patient and you order a lab, and the lab actually gets done. And the lab gets done in a lab where you can trust the result. Then you get the result back. And your patient's there for you to prescribe and act appropriately. Or you order an ultrasound, or you get a chest x-ray, and then they actually happen, like in real time, like within a month, that kind of thing. And the lab can talk to the pharmacists, and the nurses can talk to the doctors. And these different departments actually sort of function as a unit. That did not describe the public health system of the day. That did not describe the hospitals of the time. And so, what we take for granted here It just wasn't in anybody's head over there. So they had to learn from us what it meant to be a doctor, what it meant to be a nurse, what it meant to be a hospital, and how to function. And that took some time. You can't just go hire somebody and they come in and they automatically know some of those things. Accomplishments during this phase. We were very successful in retrospect recruiting expat leadership. We had wonderful hospital directors and nurse directors and medical directors that came from the United States and the Philippines and Australia and America and Europe and whatnot. And leadership is so crucial. And it's really, I think, where many of these little startup hospitals around the world, charity hospitals, faith-based hospitals, they can languish in kind of relative oblivion because, again, I do think leadership is important. And you can't really lead it from the States and go 4 times a year on a trip and then entrust it to the local, you fill in the gap, Ghanaian, leadership or wherever you're working. Yes?
So you mentioned that there were several NGO-based hospitals that started up around this time. And the hospitals that were there before were state-run.
Yeah.
And did you encounter any tension or any issues with the government in terms of human resources and you being able to provide the salary that they were most likely not able to provide? And I'm curious if there was some tension there.
Not terribly, not something that, became like one of our bigger hurdles, I would say. There's definitely was jealousy, and I'm going to share that in a minute, because we were operating right next door to another hospital, and 600 people would flock right past that hospital to sit in the doors of ours. And, of course, that doesn't make the other guys feel that good. And
was that a government hospital?
Yeah, it was a government hospital. So, which all that existed besides the few hospitals I've named were either the public health government hospitals. Back in those days, they didn't even have what I call kind of the little Chinese entrepreneurial places where little entrepreneurial businessmen created clinics, maternity clinics, this and that kind of clinics, really with a pretty big profit motive, and it wasn't really clear what that private sector looked like back then. Definitely, in fact, surveys by the WHO found that more than 50% of care given in the public or private sector did more harm than good, did not do good to the patient. Either a wrong medicine, an herb that didn't work. It was either ineffective or did harm. That's actually was the exact finding. So, not much competition for quality care back in the day. Other accomplishments, the intense training programs really did bear results, and our nurses and doctors were among the best in the nation, in high demand, and often would get poached from time to time by other organizations, but we were very proud of how that turned out. The cycle of poverty, obviously for millions, was averted, and especially this acquired poverty. So typically if you were a working poor, you were a moto driver or a rice farmer, or you had at least one cow or some chickens or something, you were pretty poor, but you were squeaking out a living. But if you got a significant disease, you'd often would have to sell your moto or sell your cow or sell your rice paddy, whatever it is. And then you became really destitute poor, penniless poor. You had no income source and, probably poor health to boot, meaning they probably didn't fix your health either. And so for millions of cases of averting that kind of a cycle by giving free care to people in need, it kept that teacher in the province working as a teacher as her toxic goiter was properly diagnosed and properly treated and saved her life and didn't cost her, anything, essentially. So that was a great accomplishment. retention of donors. Donors are a hard thing in this business. And to keep the ones we had for as long as we did was a success, I believe. Our hospital developed a national reputation. And, we did have that model that had been lacking in the country, as I mentioned. Some surprises were the eagerness and teachability of Cambodian staff, U.S. and Europe's desire to collaborate on research. We became quite a research center, certainly an unintended consequence. Our positioning to become leaders in certain areas of national development, notably HIV and AIDS. What I mean there is we would take on, and I'll tell this story maybe in a minute, but we would take on antiretroviral care back when the government had no funding. We're a poor nation. Antiretroviral drugs cost hundreds of dollars a month. There's no way we have this in our strategic plan to provide antiretroviral drugs. So they said, we had our own means and sources so we could get these and provide the proper care for HIV/AIDS patients. So when the Global Fund came along, when the global community came together and pooled a lot of money to combat HIV and AIDS, suddenly millions and millions of dollars was available to Cambodia. But nobody had any experience. The government literally turned to us and asked us to write the countrywide proposal for them to the Global Fund. So round one of the Global Fund, we wrote, in the area of HIV/AIDS. And it positioned us from then on to remain in the forefront of that country's fight. We were teaching our doctors, we had a training curriculum, how to diagnose, how to go with the labs, how to treat opportunistic infections, kind of basically how to provide a continuum of care for HIV. That had been developed in our system before there was any money for it to do anything, just out of the compassionate nature of our culture. And so when the money did come and the government was ready, we had already established that experience, and the government said, give us your teaching curriculum. And then we gave it to them. And ours was 40 days or whatever it was, and they said, make it 20. And so and we'd fight. But the fights we had were like, no, you need 40 days. No, we can only afford 20. And so, but nevertheless, it was never a matter of, can somebody else do this? We were in those positions. Same with diabetes. Nobody really knew how to use insulin properly, especially for adult diabetes. And we, became the national center and still are in that area and on in many other areas. So that was a surprise. We didn't come in with our little compassionate mission to help the poor and say, oh, we're going to be a country leader in all these things. It wasn't in our brain. We were like that girl asking for the wheelchair. It just wasn't in our head that these things would happen. As a hospital, you wouldn't think that there'd be opportunity for primary care or prevention or for social work. And we got a lot of grief at the early days that said, the last thing Cambodia needs is another hospital. Their immunization rates are only 40%, and malnutrition is rampant. And, pregnant women aren't getting antenatal visits, and on with all the primary care and all the public health kind of focus that a nation like that rightly does deserve. People were saying, what are you doing here doing curative tertiary care? I mean, it was an insult. It was a cuss word in their language, that we would be doing that. And we're like, okay, we listened, and we were like, this is a good point. But we found ways to create linkages to secondary and primary. We had home care teams that went out into these remote areas. We did TB case finding and screening. We did training in malaria and so forth and so on. And so we really did find ways to fit. And I think that was a surprise, at least to me. So I listed it under surprises. Here's Dr. Croy in the middle between myself and Dr. Saina Moore, who is a board-certified internist over there now. He's got a master's in medical education as well, so he's advising in our medical education curriculum. Dr. Croy is the leader of medical education and research for our hospital. She alone has published 20 different papers, presented dozens of abstracts and posters in international symposiums on all the inhabited continents of the world, basically. Just that little hospital, we probably have over 100 to 200 just research journal articles in international juried publications. Who'd have thunk it? That was a surprise that came together. And that happened through collaboration with people like you. That happened through collaboration with academia in the West. So, a bit of a surprise. So lessons learned, refine your vision, mission, and strategy as early as possible. It's very easy to kind of outgrow or at least need to take a new look at that early on. And be a good neighbor, to your point. And we tried our best, and there was some jealousy and there was some tension. But for the most part, I think we did that. Win the hearts of the staff. Ask the right questions. We asked a lot, what is our fit in this country? I am so glad we asked that question and so glad we asked it early. Because really, a foreign-led NGO, hospital, can be a little island of excellence and everybody go, wonderful, wonderful, good for you, keep doing it as long as it doesn't cost me any money. But we got 15 million people here that are sort of malnourished and in need of, iron and vitamins in their pregnancies, and we don't get how you fit. And I think we wrestled really hard with that. And what is your impact? I mean, you're bringing in $3 million a year. Could those $3 million be better spent? That's always an argument that you need to take seriously. And so we were always saying, how can we increase our impact, maximize our impact, leverage our impact? How do we sustain ourselves? This free hospital thing's not going to work. How is anything we're doing scalable? Can it be brought to scale? I think those were the right questions, and I think we were asking them in phase one, and I think that helped us. Challenge, as I mentioned, this fit, or can we be a catalyst? Can we somehow, catalyze something greater, or are we going to just be this little island of excellence, this little magic garden? You're lucky enough to come in our gates, you get wonderful care, the rest of the country is dying of, terrible care. That's what we didn't want to be. We had to learn the public health and the development community jargon and approach, because most of the players over there are you guys, public health people with your MPHs, or people with business degrees or something besides the MD degree. I never felt so, I don't struggle with feeling inadequate really, but I certainly in America with an MD after your name, you're not going to really worry so much about, adequacy. But over there, it's like, MD, what are you doing here? And I'm like, okay, if you throw down the gauntlet, I'm going to answer it. And I think we worked, to our credit, to really work with our public health people and say, hey, look, there's a role for both of us. So anyway, phase one, lessons learned, challenges. Okay, yeah, I'm on to the next phase. So we did move to this external capacity building. There was a time we were working, there's 23 provinces in Cambodia, we were working in 21 of them. We had people teaching malaria, teaching tuberculosis, strengthening public hospitals, evaluating public hospitals, sharing knowledge, sharing skills, training an anesthesiologist. Whole half of the country didn't even have a, working anesthesiologist back in the day. So there was a lot of work, a lot of sharing. But what the challenge with that is it stretched our staff really thin because, you send them out, well, goody for them over there, but I don't get that wonderful doctor like Dr. Croy anymore. She's not here training my doctors or our patients. And so there's kind of a limit in what you can do. But we knew it was the right thing to do, and we wanted to do it, so we put effort into it. Okay, I shared, I guess, enough as time allows for our HIV story. We were able to be one of the pioneers in the country and really help them roll that out. We did the same in orthopedics. We took a sister hospital there that was a big trauma center, and we came in and taught them how to use some more modern orthopedic hardware, how to wash their hands in between seeing patients. To do that, we had to install sinks so they could wash their hands. Some pretty primitive stuff, but at the end of the day, it really did upgrade the public health system in cases like that. Diabetes, we had telemedicine, and so forth. Surprises was the scale and the success. We went from about 20,000 budget to 2.6 million annual budget just in HIV and TB, just with the Global Fund. So unexpected surprise there. We were surprised, I was surprised anyway, the competitive of, here's a pejorative term, the Beltway bandits. Different big, rich, global NGOs sit inside the Beltway of Washington, and they are former USAID people, former government staffers, and they know how to get that money. And so they'll get that money and then come figure it out second. And they'll use people like us that actually have the know-how and say, come and work for us or teach us how to do it. And then you get kind of drippings on the dollar. They got the $30 million grant and they'll be glad to give you $200,000 of it. Where what they're doing is essentially what you're doing, what they won that grant to do. Not everybody's like that. They do a lot of good, many of these cases, but that was a very unpalatable experience to see that going on, and that happens all around the world. So I don't have a solution for it. The turf mentality of many NGOs surprised me. I've approached hospitals that I won't name because they might be sitting in this room. But, I've approached different NGOs saying, hey, if we collaborate, we might be able to go get that USAID grant for $30 million. But alone, I'm not sure we can do it. And alone, I'm not sure you can do it. How would you like to team up together? And there's a lot of guardedness, a lot of protectiveness. I don't want you in on my turf. I certainly don't want you sniffing out my donors. And there is a lot of very proprietary nature to the NGO work. And I think that surprised me because we have the common mission and the common ground. The politics in the public sector were the same way. We had government people say, Hope is getting too much money. Not that they don't deserve it, just they're getting too much. My hospital, CalMet, or some other hospital, you need to throw that money our way. Do you know how to do what they're doing? No. But we're the public, so you got to give us the money. And there was a lot of that attitude as well in, the public sector, that NGOs should be giving, not getting. They should bring their own resources to the table. And they're right, to a degree. But not every size fits all, and you have to really look at case by case. So I learned that leadership must invest time and, there's a misprint, relationships at the highest level. I spent 30 to 40% of my time as the hospital director outside of the hospital, not in my chair, not in my office, but where? At the Global Fund Secretariat meeting, at the board meeting of the NGO umbrella organization or whatever. So investing in relationships with the other NGOs, investing in relationships with the development sector, the unilateral and bilateral donors, becoming best friends with the WHO and the United Nations and all these guys that are in country, the World Bank. Why? Because if you want to have a fit in the country, you have to be a good listener and a good learner, as well as, of course, a good advocate. So just a few lessons learned there. Avoid mission creep. I'm sure we've all heard about that. There's so many needs, and in some ways, so many opportunities. It's so easy to go, I could do that. I could do that. And the next thing you know, you've lost kind of your area of expertise and your strength. So the last thing to talk about, specialization and sustainability. Here are the challenges. Sustainability, the big bogey word. How are you going to sustain what you do? If you outgrow your resources, you might have grown like this, and then you might just implode because you lost one major donor, or you had too much dependency on this or that. So that was a big, avoid over-dependency on one revenue stream, avoid mission creep. The doctors themselves have a drive to specialize just like they do in the United States. It increases their marketability. They go from being one primary care physician out of 20, which I think is wonderful, but no, they want to be the one pathologist in the whole country. And thus they became, and that they did become. So we had to then figure out, well, how do we keep this guy now that he's the only real pathologist of note in the country? Or do we? And, how does that work? So that was a issue as the kind of natural tendency to specialize. All right. Accomplishments in this phase. Specialists in almost anything we threw money at and became and decided, that this is a need and we want to do this. We became in the forefront of that field. So we wanted to go into women's health and address cervical cancer and breast cancer and some basic things like that, which in the United States are nobody dies of cervical cancer in the United States. It's a highly detectable, highly preventable disease. HPV vaccine, you name it. Over there, I think it was the leading cancer death. Shocking. A disease that kills nobody in the States is the leading cancer death. And so some of these kind of things, we just said, gosh, we got to get in here. I don't care, whether it's politically right or wrong. And in we go, and sure enough, eventually we find ourselves as thought leaders, at least, in the field. So that was cool. We did get the revenues that we needed to sustain our mission. We were able to have some fee-for-service clinics. We were able to start another hospital on a different model where there's a sliding scale. And those that could pay something would pay something. It wasn't all free. And the poor would be free. The slightly less poor would pay maybe a couple bucks, and then middle class or rich would actually pay the full price, which is still only like $20. But anyway, it worked. And it's tolerated at the moment for the government, but I don't know. Our surprises, we did lose, one key donor. We shouldn't be surprised. No donor. Everybody says no donor lasts forever. Usually they last about 3 or 5 years or 7. You make it 15, you're already doing really good. But somehow in our naive little business, we think, these will just last forever. And nothing lasts forever, right? Initially, a pleasant surprise was our staff actually didn't want to charge feast. The Cambodians had so bought in to the mission of serving the poor. They didn't want to be doctors for the rich. They didn't want to be doctors for the middle class. And I just thought, well, I kind of like that. But, they kind of adopted the ethos of the hospital, so much so that they were the biggest barrier as we tried to morph into a more sustainable way. Another surprise is I'm open to medical schools like the University of Health Sciences and International University and others are open to collaborating at some levels that are very innovative and quite exciting to me. So I think that was a surprise. Organizational buy-in is key. Organizational alignment is key. I mean, we're even just part of, again, Hope Worldwide is an organization, and we needed to work to stay aligned with the bigger parent organization, if you will. And, of course, inside of Cambodia, our 700 employees, we had to make sure that they had buy-in and felt ownership. And that's actually very hard to do because they will naturally, one, look up to you, and two, resent you at the same time. You know, it's just a funny way that they are. And they'll come to you for every question that they could solve, and yet on the other hand, they're like, what are these Americans doing here? So, you know, so it's a hard thing to navigate. All right. I'm going backwards, that's right. So let's see. I want to wrap it up. See, I hope to get some time for questions. Here's a fun one. Unintended consequences. Not always are those a bad thing. So, you know, usually if I said if you said, well, what's going to be the unintended consequence of some action? You know, you're braced for something bad. But we saw a lot of positive unintended consequences in this case study. And we started with a charitable mission to provide safe and compassionate care for the poor, period. That was the simplicity in which we went in. And who'd have thunk it? We did not expect to have the public sector impact that we had. A platform to address the issues of women's health, gender violence, HIV/AIDS, you name it. A center of excellence in medical education and research. I don't think we walked in saying, oh, this is what we're going to be. And yet this is what we were forced to be in some ways. And a platform for North-South and for South-South partnership. And if you understand that jargon, the developed world, the North, and then the developing world, the South. And a lot of times people like Dr. Victoria here in the back who came in, or an entire university. We've worked with Brown University, we've worked with Harvard, worked with the Mayo Clinic, we worked with UCLA, and on and on. And what those guys are used to doing is they go into the developing country and they're used to a pretty primitive and not fully functional situation on that end. And so you're bridging this highly charged, highly functional North, trying to make a bridge and patch it into something that's a little bit shaky. And I think what people saw with us is, wow, this is a Vanderbilt-trained, internist that's leading this thing, or this is a, Harvard-trained person here. This is quality on the South end. I can nail that 2x4 to good wood, so to speak. And I think that's an opportunity that's not fully developed by us or by maybe anybody, to be honest. And then the more newer, sort of jargon is, why do you need North-South? How about some South-South? Why don't you partner with Nigeria or Peru or, other people that are in your shoes or slightly ahead and get some learning going on there. So great opportunities for that. I'm going to skip that slide or not. The program characteristics evolved over our 20 years. Our pro-poor nature never changed. We did become more sustainable, and we say, I don't want to do anything that isn't sustainable. We've looked for replicability and scalability, and I think it's there in different ways. We want to remain a platform for compassion. We're faith-based, remember, so that's as much an essential part of what we do as being pro-poor. Wanted to be incubators of innovation, and I don't want to minimize this one. Innovation is the future, in my opinion. Nobody has all the answers. And even if they have an answer that worked here, you come into a different country and There's just no guarantees. And you have to think on your feet, and you have to be flexible, and you have to innovate. And I think if that becomes part of your culture, if you say we are an innovative organization, I think you're going to do more. Local ownership. Every hospital is run by, Cambodians, all the departments, and more, it's their baby. Untapped or nascent opportunities. I'd love to hear your thoughts at the end of this. I still don't think we've had a true public-private collaboration. And it's not clear how these will work, where the public and the private sectors really marshal forces. But we've had some preliminary discussions. I think there are possibilities there. I don't know if we as an organization have the capacity to go through those. I don't know if the time is right on the other end. Faith development collaboration. Usually these two communities don't talk to each other that much. The scientific evidence-based development community, the academia community has their approach, and they kind of look at those faith people as being amateurish and whatnot. Faith-based people, on the other hand, have their own criticisms, and the two often, are like this to each other. And yet, in the developing world, most hospitals, most schools, most social services are run by people of faith, not just Christian faith, Muslim faith, Hindu faith, Buddhist faith, whatever, you name it. But the communities of faith do so much in the poor country setting because it just aligns with values within their faith. And for a development, they can put boots on the ground. They can do a lot of things that an outside development organization can't do. On the other hand, the outside development people have the science. They have the evidence. They have, best practices that they can bring to the table. And it's a bit of a shame that these two don't at least find some little overlap with each other in their Venn diagram. But large-scale collaboration with U.S. academia, we haven't done it yet. We've dabbled. We got research papers. We got this and that. We have never found an organization, maybe University of Colorado can be one, but it will say, hey, let's really kind of link arms and just do some amazing crackerjack stuff here together. And we haven't found that. Use of social capital, again, we haven't unlocked the secret to that yet either. So, in conclusion, that's our case study. Took a long time to share it with you, but I apologize. But 20 years is a lot of time. I feel like it is a successful case study. We made a lot of mistakes, but we grew and accomplished a lot of things we didn't expect. And our footprint, we're really punching above our weight in the country. For such a small overall organization, to have had that impact on that country is really a bit of a surprise. And I think it's worth a good bit of reflection as to, why? And how did that happen? And can it be replicated or not? What are the lessons we can learn from it? So with that, I'll open it up if there are a couple questions, and then I'll bet you we're out of time after that. But what lessons from this case study are useful? What are the right questions to be asking? And here I'm asking you out of genuine curiosity, because I don't know. I'm saying, that case study being what it is, what should we be trying to learn from it? I'm open to your thoughts.
One of my problems is, and it's not limited to Cambodia, but I saw it in Vietnam, is that this thing about their desire to accelerate to Western standards at a rate that probably they should be doing with malnutrition and hygiene. They want to do transplants, cardiac surgery.
Right.
In my area, very expensive sort of things where the issues on the ground are maternal mortality and malnutrition and dengue and things like that. And I understand their desire to practice the latest and greatest, and that's how they define themselves as being doctors, is how close to Western medicine they're practicing. And so it sounds like you've tried to walk that line at your hospital, probably not offering some services that you really see a demand for, avoiding that mission creep. So could you address that a little bit further? How do you keep your doctors happy when they know there's such a thing as a dialysis machine and your hospital's not going to purchase it?
Well, I think that's a great question, and one that's a globally relevant question. It started with us. I mean, when I came in, I remember saying, okay, our goal is not to recreate Harvard in Cambodia. Our goal, and what I meant by that is our goal is not to practice medicine at the best of first world standards. We don't have an MRI. The whole country didn't have an MRI. I mean, how are we going to do it? And you want to throw resources into getting an MRI, it's just a never-ending spiral, and you'll never get there. So I think first the leadership recognizing that that's not what you want to do. What we wanted to do is provide better care than anywhere else. So, and what I call good enough care back in the day, when that phrase is now more popular, but I said good enough. Good enough means it makes you better, not worse. And so good enough care and better care than what the providers around us are doing. If you do those two things, you're going to succeed, because word of mouth will do that. Now, to your individual doctor that wants to be the dialyst, nephrologist, I think that's where capturing your value system maybe comes in a little bit. It's like, and most of those people do have a genuine love for their people and for their country. And so I think they even know, and they can restrain themselves a little bit by, if you just say, really, if we do that, we can't do this and that and the other, and we'll save tens this way, but thousands this way. And can we redirect your ambition a little bit different? So, was there a question?
I just wanted to add that Dr. Berman, the director of the center, says that the perfect is the enemy of the good.
Right.
That speaks to what you're saying.
That's true. Very good. Somebody, yeah.
What do you feel like is your biggest public health accomplishment with the hospital? Like, has anything been started, like the type 2 diabetes prevention, or like you mentioned the diabetes program? Yeah,
I do think prevention. We have our patients will meet in these little focus groups, or not focus groups, but support groups on our roof, actually. And we will go over a lot of nutrition, and then our material and whatnot will get copied by other players that are in prevention. HIV/AIDS, TB, and malaria for sure were big public health contributions. Absolutely. From not just in the antiretroviral space, but the whole continuum of care space, where we were really in some ways sending our caseworkers out into the slums and doing a lot of very primary and preventative types of work. So, and then those materials in our curricula would get, copied and modified by the government and other players. And so we see our influence all across Cambodia. Let me do this one and then back to you. Yeah.
So coming off of that, has the standard of care in Cambodia increased with your care as the model? Because now, like you were saying, the hospital right next door was seeing all of these people just parade by. So has the standard of care changed at all in those specific places?
Yeah. I mean, and not only, we're just one player, and we're not going to ever take credit for any sort of accomplishment in that country, in and of ourselves. We're one contributing player. And the standard of care has come up, but it still has a long way to go. And some of the factors, to digress slightly, is that the quality of the medical student is dependent on the quality of the college student or the high school. They have a French system. So right out of high school, you go into a 6, 7, 8-year medical school. Quality of that high school student is a function of low primary education, and education has been something you could just buy your way into a pass and move your way on up. And so people, 6th graders aren't as smart as our 6th graders, aren't as educated. I take that back because they're absolutely as smart. They're very clever, resourceful people, but their level of education lags behind at the 6th grade level and the 12th grade level and the med school level. And to change that, you really have to come all the way back. And that's why we have a school there. You have to come all the way back and fix that whole system. So the doctors graduating with MDs after their name are still, I asked one, tell me what you know about diabetes. And he said, well, it's no insulin. Okay, where's insulin made? Pancreas. Right, good. Anything else you can tell me? And that was about the extent of his knowledge. So insulin resistance. I said, insulin resistance? That ring a bell? Target organ, muscle, fat, liver? Nope. Kind of pancreas makes insulin, diabetes, something's wrong with that system. Well, this was a doctor. He came out of medical school with that level of knowledge. This is a while back. So back to your question. Yes, the standard of care has gone up, and yeah, we've played a role, especially in the postgraduate space. But much still needs to be done in that whole pipeline. Okay.
I think we'll wrap it up. Dr. Duster,
All right. Thanks, everybody. I'll tell you what I'll do. You could get if anybody wants to shoot me an email, I'll just do this. I'll put cards here if you want to shoot me a question by email, or ask about a volunteer opportunity. Otherwise, thank you for the opportunity.
Thank you.
What percentage of your income stream comes from the